Hi everyone, my name's Abby and I'm one of the mental health researchers working on the Parity of Esteem review, which comes under the ARC Greater Manchester Mental Health theme. And I'm here to talk a bit more today about how in the project we involved and worked with service users and carers to define and measure equality between mental and physical health, or Parity of Esteem. And the chief investigator for this programme and this project is Professor Karina Lovell. So I'm just going to give a bit of an overview and a background to the project and Parity of Esteem, talk a bit about the methods that we used, some of the results that came out, and then a real focus on how we involved service users and carers as part of the project, and then happy to take any questions on the day. So Parity of Esteem, what did we already know? Well, it was first mentioned in No Health Without Mental Health in 2011, where it gave a real kind of responsibility across government to really focus on equality between mental and physical health. And it was then included within the Health and Social Care Act of 2012. And that actually gave legal responsibility to the Secretary of State for Health to really focus on equality between mental and physical health, now that it's kind of been enshrined within legislation. And the Royal College of Psychiatrists first kind of defined the term as valuing mental health equally with physical health in 2013. And there's a few key areas which I'll touch on now that they mention should really be included and thought about when we think about parity between mental and physical health. So the Royal College of Psychiatrists touch on these key areas around how we might achieve equality between both sides. So in terms of equal access to the most effective and safest care and treatment, equal efforts to improve the quality of care, equal allocation of time, effort and resources based on need, equal status within healthcare education and practice, and equally high aspirations for service users and kind of satisfactions with care, and equally high status in the measurement of health outcomes. So these are the key areas that the group kind of thought, well, actually, if we're looking for equality between mental and physical health care, we need to think about these key areas, and this is what people should be experiencing. So why is this work important? Well, it's currently quite unclear how parity of esteem is really defined and how it should be measured in practice and what that really looks like in reality. And it's important as an overall holistic approach to healthcare when we think about individuals and patients and how people live their lives. That overall kind of mental and physical health equality coming together and well-being is really key when we think about both of those. So the aims and objectives of this project, the aim overall was to explore the meaning of parity of esteem and provide some key indicators to guide future research and policy, and also serve as kind of improvement and development. And the key objective areas that we had were to firstly compare and contrast different definitions of parity of esteem and identify any potential indicators within existing literature. Secondly, to understand stakeholder perspectives on parity of esteem between mental and physical health. So that was from health professionals and also those who use services and their carers. And third and finally, to identify measurable indicators through this work for parity of esteem for future research and service development and improvement. So these were real key areas that we wanted to focus on as part of this work, which I'll touch on now. So in terms of the methods, we overall kind of had two key areas that we focused on to channel into a priority setting event. So we started with a systematic scoping review, which is where we basically had a look at the literature, had a look at what was already out there around parity of esteem, and then thought about how much we've kind of learned from that and if there are any gaps. And then on the other side, we had our kind of stakeholder engagement, which involved healthcare professional interviews and service user and carer discussion groups, which I'll talk about a bit more. And we fed all of this into our priority setting event, which was our main final event where we brought all of the findings together so far and had a final kind of discussion to come out with some key indicators in areas that we might focus on if we're thinking about parity. So the systematic scoping review was a way to kind of review the general body of literature and identify existing definitions on parity of esteem. It's really just to understand what's already out there in articles, government kind of reports and other literature, and also within kind of charity websites and different kind of organizations that talk about this a bit more. So we're still kind of going through the process of this, but some of the early findings and key things that came out to me as I kind of was involved in this is that there's a real variation around the definition. There's talk about equity, equality, valuing mental and physical health, but actually those can mean different things in reality. So actually that is quite varied and quite vague in some terms. there's a massive amount of US literature. So in the US, they've actually got a parity law, and it gives insurers a legal responsibility to make sure that they give insurance, equal insurance coverage for medical and surgical treatment as they do for behavioural treatment. So it really brings together that equality and parity in literature, within legislation. So that was really interesting that came out from the US literature, is actually how that is involved in legislation and what that means in real terms on the ground. And finally, that there's a real lack of clear indicators and updates on progress on parity within the UK here, which is the main focus of this work. And that was quite interesting to think about. Well, actually, back in 2011, this is when this term was first used, and there's really not that much kind of clear indication on the progress that we've made here. So those are some of the key things that have come out so far. So our health professional interviews focused on mental and physical health kind of professionals from lots of different services, including policy, charities, different clinicians and academics. And we interviewed them through Zoom or on the phone, as we weren't able to do face-to-face due to the restrictions of the pandemic. So we interviewed 20 mental health professionals and 7 physical health professionals. So in terms of our topic guide and what we asked the interviewees, these are the 4 key areas. So we asked them around the definition of parity of esteem. Were they familiar around it? What did it mean to them? How do they understand it? And in terms of their views on the concept of parity of esteem, is it useful within their sort of area of work? How do they use it in the day-to-day? And is it a useful term when we think about it within our NHS services? And some questions that came under indicators looked at, well, actually, what are the most important indicators to you if you think about parity of esteem and that equality between mental and physical health? Which ones would you pick as your top 3? Would they be easy to measure? Are there any indicators which you think might not be easy to measure? And we used some of the findings from the systematic review, where we reviewed the literature, to feed into that. And in the final section, implementation and accountability, really looked at, well, who do you think is responsible? Is it the government? Is it the NHS? Is it someone else? And who should have that accountability about whether we are achieving parity of esteem or not? So in terms of our results, I'll just touch on briefly some of the areas, as I don't have the time to go through everything, but I just wanted to kind of give some key indications of what came out. So it was really interesting just overall thinking about, well, something in policy versus practice and how important language is. You know, we've got the term parity of esteem, talking about mental and physical health equality, but actually, what does that actually mean in practice when we're on the ground? What does that look like? And I think that comes out a lot in some of the results that we had. And translating, as I said, policies to the ground is really important, because actually, if you've got a term within policy and within literature, what is that going to mean in the day-to-day? And we need to really have a clear grip on what that means for people who kind of provide services to people and people who experience services. They need to know what that actually means to them. And finally, that there's a real confusion around the term and how service users and how healthcare professionals see it, and actually how there might be some areas of agreement, actually quite a lot of confusion just all around in terms of how people experience services and what they see parity of esteem to be, and actually how professionals see it within their line of work or what it means to them. So that was really a key thing and an interesting thing that came out through this work. So the key themes from the interviews with the professionals came out to quite a few of these themes, and it's going to be discussed more in the paper that we're kind of working on now. But these are some of the key areas. So I'll talk a bit about a few of them and just give a few quotes that came out, which I think might be interesting. So firstly, rhetoric and resistance. So interviewees talked a lot about how there's a lot of confusion around the term parity of esteem. There's a real lack of clarity. It can mean a lot of different things to different people. And actually, that could be a good thing. As much as it can be negative and quite confusing, that actually is positive in terms of advocating for parity of esteem and that equality between mental and physical health. And it was really focused on kind of political conflicts and actually how that was really used within the political landscape a lot, and how that can actually be quite confusing and needs more clarification in healthcare. So one person we interviewed said, well, I think actually very few people understand the full nature and breadth of what parity of esteem means, and it means a lot of stuff. And I think that's quite interesting when we think about that sort of confusion that I touched on earlier, that this interviewee thought, actually, this can mean lots of different things to different people, and it is quite vague. So training and resources was another area. So training in diversity and cultural competence increases parity. A lack of education and training leads to a reduction in parity. And reduced time on the curriculum and how people are learning really emphasises that lack of parity between physical and mental health. And a skills mix on a team really is important if we're looking at health kind of teams and health services. It's really important for that parity. So this was a really interesting one that came out quite a bit within interviews, and how actually, you know, if there's an increase in training and diversity, that's really key for parity of esteem. And if people aren't really learning about it as part of their curriculum and how they're being trained to be health professionals to provide services, well, actually, if there's a lack of education on one side or the other, then actually we're going to have a real reduction in parity. And we need to make sure that people are learning about both mental and physical healthcare equally. And a reduced kind of time spent on the curriculum is a really interesting one. My colleague, Janine Owens, who led this project, kind of noticed that in medical degrees, there's only 1% of the entire degree is spent around mental health specifically. And I think if we think about how that might roll out in services, it's really interesting to think about, well, how are people learning and how does that play out within practice? So in this quote here, an interview said, "I just don't know how to deal with a mental health patient. I don't know how to deal with mental health needs, and I'm a bit fearful of it. And there's just a real lack of training and understanding of what we need to be doing." And I think that was quite brutally honest, actually, and quite interesting that that person just felt honest enough to say, actually, I don't feel qualified, I don't feel ready, I don't feel that I can kind of be, you know, responsible in that sort of situation. And I think that really shows a lot around how training, resources and education is really key. And kind of targets and incentives is a final area that I'll just briefly touch on. There's a real lack of clarity when we're setting targets and what that means for parity of esteem. And sometimes it can be quite difficult to achieve it. And if you might incentivize targets or, you know, give kind of means and positive ways that people should try and reach parity of esteem, well, that's only going to be related to the incentives that you provide, for example, if they're financial. And the types of payment again, might affect that sort of parity of esteem in reality and in practice. So here someone said, if you incentivize GPs to perform a mental health review every 3 months in someone with a mental health condition, they'll perform it. But the real question is, will there be a better outcome? You know, we can have targets and we can make sure that, you know, GPs are ensuring that reviews are happening, but actually what is the actual kind of experience for that patient? Are they still feeling that their kind of mental health is being considered? Or is there actually a real kind of, you know, core question of like, is the outcome something that we really need to focus on in terms of the experience? You know, let's not just keep reaching targets, but actually think about what the actual experience is for people. So how did we work with service users and carers as part of the project? So we had a patient advisory group, or a PAG, which involved 3 people who were service users or carers of someone with a kind of mental illness or condition, and they were part of our research team, our core research team, and they kind of sat within it. It wasn't something that was kind of working in silo with us on the project. It was actually a group that were part of our core team. And they provided feedback on lots of different things and got involved in lots of different ways. But the main ways were through kind of our research materials. So if we created a topic guide for the interview with questions, we asked them if they felt those were appropriate, if there was anything we'd missed out. And that was really key and really useful, because actually there were some questions, some areas that we hadn't considered. For example, one person had spoken a bit about, well, actually, we need to think about parity in terms of carers as well and family members, and start asking those questions. And so we included that question as part of the interviews that we did with health professionals. So that was really important to kind of send it out, because as a research team, you know, sometimes we're kind of looking insular at like what we want to find out. So it's really important that we included the group as part of that. And they helped with some of our other kind of research materials, and also with planning the events, such as the discussion groups and the priority setting event. And they provided a lot of feedback and thoughts on that, which was great. They've also been involved in our research dissemination or how we share results. And that includes a video, which they're currently working on with some other people that were involved in the project. And so that's really looking at how we just summarize our findings, how we want to kind of share the results, and how we want people to understand parity of esteem a bit more from what we found out. So they've been involved in that too. And I think it's just really key to kind of really focus on the fact that people have experiences, and people, you know, as a research team, you know, there can be things we want to find out and things we're focused on from our kind of research point of view. But actually, people have experiences that they want to share, and they can be really valuable in terms of insight and just kind of opinions and voices in terms of how we shape the work that we're doing. And it's really important that if we're doing this research for a reason, we really do involve people that have lived experience. So also we had discussion groups. So we invited service users and carers who use mental and physical health services to be involved in our discussion groups. So these were slightly different to the interviews where we had a group of service users or carers who came together over Zoom, again, just to discuss a bit more about kind of parity of esteem and what it meant to them. And so we kind of had two main questions where we focused on what would it kind of look like to you? What is the thing, if you think about parity of esteem, that would be important to you as you access a service? So that could have been around sort of access of information, you know, waiting times, treatment choice, treatment options, things like that. And we thought a bit more about, well, actually, what does that actually mean when people access these services? So that was a really, really interesting and valuable kind of time we spent talking to people within the local kind of area within Manchester. And as we moved to Zoom, we were able to involve people who weren't necessarily within Manchester. And so we also had, just quite a varied group of people. So some of the groups that we involved were the Caribbean African Health Network within Greater Manchester, the Research Methods Group, which is within the university, and the ARC PCIE panel, so a community panel that sits within the ARC programme. So some key themes that came out was that there was a real lack of accessibility of information when we're thinking about mental health services. So people spoke about, well, if I break my leg and I go to the physical health service, it's quite easy to understand the information or the options that are available to me. Whereas for mental health, that information isn't always that accessible. It can be a bit confusing. It's not always that clear. So that was a really interesting theme that came out around satisfaction of care as well. So people spoke about, well, you know, there's a lot of focus sometimes on, am I taking the medication? If not, why not? And actually not really getting to the core of why that might be. If someone's not kind of sticking to their treatment plan, well, we need to think a bit more about why that could be. You know, there could be a core reason behind it. So some people felt that they were being rushed in some of those appointments with a professional, and they wanted to feel that actually, you know, they could really get to the core of that. And finally, just a lack of integration of services. So people spoke quite openly about, you know, if I have a mental and physical health need, why is it that I need to go to separate trusts that might be literally across the road from each other? You know, there needs to be a real integration if we're thinking about, as I said before, that holistic care, that people feel that they can go to they can be within the same kind of place. Why does there need to be that separation? And finally, just briefly, we had a priority setting event where professionals and service users who had been interviewed or had been part of the discussion groups came to take part. And the aim of the event was just to discuss the possible indicators that we might use for parity of esteem in the future, and to prioritise the top 3 to 5 for further improvement in services and research. So one of the key ones that came out was around emergency kind of care and crisis care. And we're kind of really pinning together how we might go forward with some of those that we found. So briefly, in terms of the impact of COVID-19 and the lessons learned, we found that technology can be good and bad in terms of patient and public involvement in research. So, you know, obviously we missed that face-to-face of being in front of people and having those really core and important conversations. And some of that can be lost over Zoom, unfortunately, and over kind of virtual means. But actually, it made us get creative. It was great to see how we kind of rallied together and worked with our patient advisory group to do the discussion groups, but also how when we came to our priority setting event, you know, my colleague Kirsten created small conference packs and sent out like biscuits and teas and coffees to people, and it gave that personalization that we couldn't quite have face to face. So it was interesting in a way in terms of forcing us to get creative. And it also meant that we were able to kind of foster new relationships remotely, which is good, but also can be difficult. You know, when you're relying on email, you're not able to pop over to someone's office or kind of bring someone in their office. You know, it's difficult. So actually it meant that there was quite a lot that was reliant on kind of email communication. And sometimes that is quite hard when, from a research perspective, sometimes reliant on time. So just in terms of the next steps of the project, there's further analysis to do and a write-up to kind of conduct and think about kind of papers and things like that. And we're doing a kind of further piece of work thinking about a collaboration with local services in terms of service improvement and development. So taking the 3 sort of key areas that came out from the priority setting event and taking that forward into how we might work more within ARC, but also just more generally within local services to really pin down ways that we can really achieve that parity. Thank you so much for listening, and I'm happy to take any questions on the day. Thank you.